Let me give you a scene you'll recognize. The client, let's call her Dana, and she's a composite, not a real person, comes in after a day that, on paper, was fine. No catastrophe. Here's what actually happened. In a meeting, she offered an idea. The room moved on. 8 minutes later, a colleague said the same thing and got a round of, "Great point." On the way out, someone reached over and touched her hair. Then security asked for her badge at a door nobody else got stopped at. Small, deniable, each one by itself, something she could talk herself out of being bothered by. And by the time Dana sits down across from you, her nervous system is lit up. If you didn't know what you were looking at, you might reach for a single incident frame and go hunting for the big one, big trauma. But there isn't one big thing. There are 1,000 small things stacked in a context that isn't over when she leaves the building. So here's what we're doing today, and it's a little different from a usual episode. We're going to take Dana and walk her through EMDR, phase by phase, and at each phase I'll show you where and how we attune the work. Not in the abstract, in action, and I want to be clear about the spirit of it up front. EMDR is one of the most well-supported trauma treatments we have. I'm EMDR certified. I use it. I trust the evidence. This isn't a critique of the protocol. It's a master class, so to speak, in applying it with care in a way the model itself supports. This is target memory, and let's go. So welcome back to Target Memory, and the show is about the cases and the parts of ourselves that don't move in a straight line. And clinicians who are listening, quick note, this episode is eligible for free continuing education credits through Learn at Pinnacle. Credits handled in their app, and I'll point you there at the end. So since this carries continuing education, here are your objectives. By the end of this episode, you'll be able to define race-based traumatic stress and distinguish it from single-event PTSD. Explain how the AIP model accommodates culturally attuned conceptualization. Describe attunements across EMDR's history-taking, preparation, and assessment phases, and apply at least one of those strategies to a case. We'll build all four through Dana as our vignette study. And the line I mean every time. This is educational. This is not therapy, not clinical supervision, not consultation on a specific case. Remember, Dana is a composite for teaching. Okay, let's begin where the work begins, with understanding what Dana is actually carrying. So what Dana is carrying, the construct. So before we touch a protocol, we need the right name for the problem, because if we misname it, we'll mistarget it. Robert Carter's work, published in The Counseling Psychologist in 2007, describes race-based traumatic stress, the psychological and emotional injury that can follow experiences of racism. The distinction I want you to be able to make, clearly, is how this differs from classic single-incident PTSD. Single-incident PTSD typically organizes around a discrete event, a car accident, an assault, something we can locate in time and target. Race-based traumatic stress is frequently described as cumulative and in many cases ongoing. Many experiences over time inside a context that may still be present. That's Dana exactly. If you sit her down and ask, "What's the trauma?" she may not have an answer that fits the form. There's no single worst day. There's the meeting and the hair and the badge. Behind those, the version of all three from last month and last year and a decade of them. The injury isn't one wound, it's the accumulation, and critically, it's not post. It's something that she's going to go back to at that building at work tomorrow. So why does naming this precisely matter clinically? Well, because a 2025 mixed methods systematic review and meta-analysis in trauma, violence, and abuse by Lewis and colleagues notes higher PTSD prevalence among some racial and ethnic minority groups and examines how trauma assessment and treatment get culturally adapted. This isn't a fringe concern. It's a documented clinical competency question, and it sits squarely inside professional expectations. The American Psychological Association's multicultural guidelines frame attention to culture, identity, and context as part of competent ethical practice. So when we attune Dana's treatment to her cultural reality, we're not being trendy. We're doing the job the standards ask us to do. Phase 1. With Dana, history taking and the AIP lens. So phase 1 of EMDR is history taking and treatment planning. This is where attunement starts because how we listen shapes what we find. Here's the trap with Dana. If I run history taking looking only for capital T trauma, I may come up empty, write no significant trauma history, and miss the entire clinical picture. So the first attunement is in the listening. I ask about the everyday, the meetings, the commute, the doctor's wife, the 1,000 small contacts with a world that keeps signaling she doesn't fully belong. The culturally informed trauma literature, including work on adapting trauma treatment for clients affected by racism, specifically recommends asking directly about these experiences rather than waiting for the client to volunteer them, because clients often don't expect us to count them as clinical. Now, how does the adaptive information processing model hold this? AIP, Francine Shapiro's framework, the theory under EMDR says that distress comes from experiences stored in an unprocessed form, and healing comes from helping the brain reprocess them adaptively. Look at Dana through that lens. Each small incident on its own looked too minor to count, but unprocessed, they don't stay separate. They consolidate into a network, a felt sense of, I have to stay braced, I am not fully safe in these rooms. That network is exactly what AIP describes, maladaptively stored experiences linked by theme and affect. And here's the part I most want to be precise and respectful about. Working with Dana this way is not a workaround of EMDR. It's AIP applied with care. Mark Nickerson's 2017 text on culturally competent EMDR from Springer explicitly describes enriching the adaptive information processing model with knowledge of social information processing. That is, accounting for how social and cultural experience shapes what gets encoded and how. The field built this on purpose, and the Journal of EMDR Practice and Research has published empirical work on adapting the standard 8-phase protocol across cultures, a qualitative study across 5 African countries documenting culturally appropriate adjustments that preserve the integrity of the approach. So with Dana, we're standing on published ground. Practically, phase 1 with Dana produces a target sequence, not a single target. We might use a standard EMDR technique, the float back or affect bridge, taking a recent charge moment, say the badge at the door, and inviting Dana to let her mind drift back to earlier times she felt that same body sense. That's how we find the touchstone. The early experience, the present ones are hooked to. Same standard EMDR move, we've just aimed it at the right material. Let me slow down on the listening itself, because this is where a lot of well-meaning clinicians lose the case before it starts. When Dana describes the meeting, the idea ignored, then repeated and praised, there's a temptation to soothe it away in the room. Well, maybe they just didn't hear you the first time. Do that, and you've just done, in a miniature, the exact thing the world keeps doing to her, explaining away her perception. The attuned move is the opposite. We validate the pattern recognition. We treat her read of that room as data, not distortion. The culturally informed trauma literature is consistent here, bringing race-related experience explicitly into the assessment rather than waiting and hoping the client raises it is part of competent practice. And there's a clinical payoff. When Dana feels her experience counted rather than minimized, the therapeutic alliance which we'll need for everything downstream actually starts to form and fortify. One more. Phase 1 nuance. With cumulative race-based stress, the target sequence may include not only Dana's own experiences, but transmitted ones. The things she absorbs from family, the warnings, the stories, the body knowledge of what it costs to be visible in certain rooms. That's the intergenerational layer. We don't have to process all of it, but we conceptualize it, because it tells us why a small present-day event can carry such a large charge. The charge isn't irrational, it's loaded by history. Phase 2 with Dana, preparation and resourcing. So phase 2 is preparation, stabilization, resourcing, building the client's capacity to do the work. This is where the safe place question we opened with actually lands. So you can ask a client to identify a safe place, but there may be those cases of a client that cannot identify one. So I sit with Dana and offer the standard invitation. Bring up a calm or safe place, and Dana goes quiet. Not resisting, searching, and searching. Searching a mental map where safe and unobserved rarely show up in the same street. If I don't understand what I'm watching, I might mislabel it. Poor candidate and not ready, treatment resistant. But here is what is true, and is important for respecting the protocol. EMDR already anticipates this. The field uses calm or peaceful place language precisely because safe doesn't fit every client, and resource development and installation, RDI, exists as a recognized preparation strategy for exactly the situation. So when Dana can't find a global safe place, I'm not improvising outside the model, I'm using the model's own flexibility. So what do I actually do with Dana? three things and watch how ordinary they are. First, I shrink the scale. Instead of a sweeping safe place, I ask for one specific real moment of steadiness. Her kitchen on a Sunday morning. The first sip of coffee before the day starts. Small and true beats, vast and fictional. Second, I consider a relational resource. Maybe Dana doesn't have a safe place, but she has a person, a grandmother, a best friend, a mentor, in whose presence her shoulders drop. RDI lets us install that. Third, and this is where cultural attunement gets specific, I invite ancestral and culturally rooted resources. I might ask Dana, who in your family or your history already knows something about getting through this? And maybe she lands on a grandmother who raised 6 kids through far worse and never folded. We can develop that figure as a resource. The broader culturally responsive trauma literature, including Resmaa Menaken's work on intergenerational and embodied resilience, speaks to why these resources can be so durable. They're not invented in the room. Dana already carries them. Notice every one of those 3 is standard EMDR preparation. Sizing the resource, relational resourcing, RDI. I didn't break the protocol for Dana. I fit it to her. Phase 3 with Dana, assessing the cognitions. Phase 3 is assessment. We select the target memory and identify its components. The image, the negative cognition, the positive cognition, the validity of that positive cognition, and the emotions, the body sensations, the disturbance level, or the SUDS rating. Attunement shows up most visibly in the cognitions. So one of EMDR's real strengths is that cognitions are client-generated. The protocol is built to honor the client's own meaning, not to impose ours. Cultural attunement is just applying that design with care. So we take Dana's touch tone, let's say an earlier memory, one at 8 years old, raising her hand with the right answer and being passed over, then watching another kid get praised for it minutes later. We find the negative cognition. For Dana, it might be, I don't matter, or I have to be twice as good to be seen. Standard and client-generated. Now the positive cognition, and here's where a clinician on autopilot can stumble. The reflective pairing for a not safe or not enough negative cognition is often something like, I am safe now, or I am fine as I am. For many clients, perfect, but imagine offering Dana, I am completely safe at work now. Part of her, the accurate reality testing part, may quietly reject it because in her actual life, in some rooms, that isn't reliably true yet. And EMDR's own emphasis on client resident cognitions is exactly what tells us to keep going until we find one that is. So we collaborate toward a positive cognition that's both adaptive and honest. Not a blanket safety claim the world keeps contradicting, but something like, I have value whether or not they see it, or I can trust my own read of what's happening, or I have the strength to protect myself. Feel the difference? These don't ask Dana to override her own accurate perception. They give her something forward-moving that's also true. That's not a softer EMDR. That's a more precise one, and it's the protocol used as designed. Client-generated, client-resonant, validity checked. A note on brain spotting. Since some of you use David Grant's approach, since some of you use it, David Grant's approach involves analogous considerations in its own preparation and resourcing, attending to the body, and to where a client can tolerate processing from with the same attunement. The principle carries both methods, fit the preparation and the meaning making to the actual person. So let me finish phase 3 promptly, because the other components matter too, and attunement runs through all of them. So after the image and the cognitions, we identify the emotions, the body sensations, the baseline disturbance, or the subjective units of disturbance, or SUDS, and the validity of cognition, VOC, which means how true that positive belief feels on a 1 to 7 scale. So here's where attunement shows up again. So when Dana rates the validity of I have value whether or not they see it, and it comes in low, say a 2. A clinician on autopilot might read that as a problem to push past. But for Dana, a low number may be accurate reporting. The belief is aspirational and the world hasn't fully cooperated with it yet. We don't argue her up the scale. We let reprocessing do its work and we let the number move honestly as it moves. Forcing the validity of cognition is just another way of asking her to perform a belief she doesn't hold, and she'll feel it. And the body sensations. So don't rush past these with a client like Dana. The bracing she described in the cold open, the lit up nervous system, lives somewhere specific. The jaw, the shoulders, the gut. Naming it precisely in phase 3 matters because That somatic thread is often where the cumulative material is actually held. The incidents may blur together in narrative memory, but the body kept a clear record. So processing and pacing with Dana. So I'll keep this part brief because reprocessing itself, which is phases 4, 5, and 6, runs on standard EMDR mechanics, but two attunements are worth naming because they protect the work. First, pacing and the cognitive interweave. So as Dana processes the touchstone, present day material may keep arriving because remember, her stressor is not over. The interweaves we offer should respect that reality. We're not steering Dana toward it's all in the past. You're safe now because that would be both clinically off and frankly untrue. We're keeping and helping her metabolize the old material so the present day version stops landing with the full weight of the entire stack. The goal is not to convince Dana the world is safe now, it's to help her carry the truth of her experience without flattening it. So let me make the interweaves concrete because this is a place clinicians genuinely get stuck. Say Dana's processing stalls. She loops on, I should have said something, I should have pushed back. A reflective interweave might be, you did the best you could. Fine, but then an attuned interweave meets the real bind she was in. My At 8 years old in that classroom, what would have happened if you'd push back and let Dana arrive herself at the recognition that her silence was a survival calculation, not a failure. That's a responsibility interweave used as designed, aimed at the actual context, or when she struck on safety, rather than installing a fake, you're safe now, we might interweave toward agency. What helps you know when a room is or isn't safe? Strengthening her own threat detection rather than overriding it. We're working with her accurate perception, not against it. Second, the therapeutic relationship itself. The culturally informed trauma literature is consistent on this. For clients carrying racialized trauma, trust with the clinician is not a given, and it may need to be built deliberately and over more time, particularly across difference. Some of that literature specifically recommends more time on the front end to establish rapport before trauma processing begins. That's not a detour from the work. With Dana, it is the work in phase 2 and beyond. A rushed alliance is a fragile container, and reprocessing needs a sturdy one. And if you, the clinician, differ from Dana in ways that map onto her experience of being unseen, that's not something to pretend away. Naming it with humility can itself be part of building the trust the work depends on. And then closure and reevaluation proceed as they always do, with the added attunement that we're checking in on a stressor that's still live, not sealed in the past. We resource for the week ahead, not just a session behind. So, what to carry into the next case, the next session? So, let me pull it into 3 things that you can use, all drawn from what we just did in the Dana vignette. 1, in history taking, talk about and ask about the everyday, not just the catastrophic. If you only hunt for the one big event, you'll miss the cumulative picture. Ask directly about ordinary, repeated experiences. Name them as worth counting. 2, when resourcing is hard, develop rather than assume. If a client can't find a safe or calm place, stay in preparation. Shrink the scale, try a relational resource, use RDI, and invite culturally rooted or ancestral resources that the client already carries. All standard EMDR preparation attuned. 3, make the positive cognition adaptive and true. Before you install, check whether it fits the client's lived reality. If a blanket safety statement does not land, collaborate toward one that it's both forward moving and honest, often about value, self trust, resilience, or lineage. That's the protocol used as designed. None of this asks you to leave EMDR or brain spotting behind or to deviate from fidelity to the treatment protocol. Everything that we covered in Dana's case was inside the methods, and it focused on competence, fidelity, consistent application of these effective evidence-based tools to the specific person in the chair. So here's where I'll leave you. So EMDR is among the most well-supported trauma treatment available. And the AIP model, the 8-phase treatment model of EMDR that grounds it, is at its heart about meeting experience as it actually stored in a particular person. Everything we did with Dana was a expression of that, supported by the EMDR literature and consistent with the model, and also aligned with our current professional multiculturalism, cultural humility, and competent standards. So we did not bend the protocol for Dana, we just brought it all the way to her. And we tailored the resourcing preparation towards her actual experience. So if a real client came to mind while we walked through Dana's case, and for many, one really did, that's the case to bring to your next consultation and a good reason to keep reading the literature. So this competency that deepens with study, and it's not a box you just check once. So, okay, so for the continuing education that you get for listening to this episode, it is through Learn at Pinnacle, and you claim it in the app. The link is in the show notes. So this has been Target Memory, where we bring tools all the way to the specific person in front of us. We will see you next episode. And for those of you that are EMDR trained, meaning you've completed basic training with an EMDR approved trainer, you've completed the 10 consultation sessions, and you have an EMDR trained certificate, but you now want to work on becoming EMDR certified, well, the good news is you can work with anyone that is an approved trainer or a consultant in training. So every Sunday at 5 p.m. Pacific, I have my virtual consultations for certification, and the focus of these consultations is around working with perpetrator interjects, cognitive interweaves, working with blocking beliefs. And as a consultant in training, attending my consultations, you can accrue, we are able to give you up to 15 of the 20 required consultations that are needed in qualifying for certification. So the advantage of working with a consultant in training is that actually they are under the training of an approved consultant who monitors the quality of the trainings for fidelity of the model and also for the quality of clinical care. So the real benefit is that the price points to work with a consultant in training are often more affordable than to work with a full approved consultant. So anyways, if you are listening to this episode and would like to dig deeper into perpetrator interjects as it relates to cases like Dana or others, and see it from the lens of how the AIP model and how treatment fidelity can still stay congruent but adaptive to working with perpetrator interjects and some of the other nuances in complex cases, then you are welcome to join us. So once again, this has been Target Memory, and don't forget to claim your free continuing education credit in the link below from Learning at Pinnacle. And until next time, this is Target Memory.